Years ago, and I was in a workshop with her, and I was amazed at her ability to take very complicated matters clinically and make them very simple to understand. And her ability to do that with anyone. She's very humble, but she's very driven, and she's very passionate. And so I really feel privileged to know her as a friend and as a practitioner and as a fellow researcher, which she will deny until her death. But she really is inspiring in her ability to have vision in this field before most of us did. So the bravery that this woman did, she was the chair of CORE with very, very little. She's like, I'll be the chair of CORE, and CORE is AE's Council on Research and Evaluation. So she decided to be the chair of CORE because some folks that were friends of hers said, you'd be a great chair. And she walked around being like, I really don't know that much about research, but I know researchers. And her passion and her ability to kind of gather the wagons really is why we're all here today. So I'm really privileged to introduce Dr. Bobbi Beale from Child and Adolescent Behavioral Health. All right. Beale and Tucker.
All right, so nerve-wracking to do this. I think I'll get in the groove here in a few minutes, but yeah. Okay, so let's all take a breath together. Cool off our brains. So I believe some of you heard me say yesterday that I was intentionally a PsyD, not a PhD, to avoid research. The same can be said of neuroscience, which I've stumbled into accidentally and forever. And so have you, whether you realize it or not. And another thing I'd like to say before I launch into a series of slides that I hope will keep me on track with what's going on. I'm so lucky. I'm so lucky. I'm lucky in life. And I think that needs to be acknowledged. Some people go into our field of adventure therapy, but field of behavioral or mental health as well, because they aren't so lucky, because they're trying to fix some wrongs and some injustices and some disabilities. But that's not me. I'm really lucky. I had a great family. I have a great family. My sister's sitting over there. I'm the oldest of 7. And we're all alive and kicking, and my parents are as well. I missed the last AEE International Conference because our grandmother died, and it was the thing to do to stay with that giant family of mine. And I was very sad and missed you all, but and it wasn't a tragedy. It was actually sort of a celebration of a life well lived. And so I'm so lucky, and I come from a position of privilege. And I want you to know that I'm not pretending that I've climbed from the ashes somehow. But another thing I'm super lucky about is meeting AE. They've given me the support for my drives and my passions for 15 years now, maybe, something like that. And it's been really a nice relationship that I've had with AE. I came up through the Heartland, meeting Tony and Gary way back when. And did some time being a volunteer there in the Heartland Council. Moved into the CRC level of the organization, and then just as I was about to venture into TAPG, CORE called, and I said, this is important work. Somebody needs to sort of gather what we have, because what we have is unbelievably phenomenal. We all know this. Don't you know in your hearts how effective this work is? It just is. Now, what do we do about it? And how can we help the world? So that's my perspective. My current role in the world is I'm a mid-level administrator in a mid-sized community behavioral health center. We have about 160 employees. Maybe about 90 of them are providers, therapists, psychiatrists, CPSTs, or case managers, that sort of thing. And I am in charge of all things group there, because years ago I said I think we could do group therapy. Like some of you in the audience, or some of the people I've heard from, I kind of thought I invented adventure therapy years and years ago. I went to a workshop called the Buckeye Leadership Workshop, and it was 4-H people. And they played all these games and had all these challenges and did all this fun stuff. And their camps had ropes courses, and I had not seen those sorts of things. And it was magical. And I took all their activities back and immediately implemented them into group therapy. And then one of the guys, I went back there year after year for about 5 years, and a guy there that I got to be quite friendly with took me by the hand and said, "I don't think you found your people yet." I said, "What do you mean, Jim Payne?" And he said, "Come with me to AEE." And that was the end of the Buckeye Leadership Workshop. I was like, okay, here you are, and we're all doing this work. So that's a little bit, a picture of my history and how I got here. I am a reluctant researcher, a reluctant neuroscientist. If you had to wait for me to understand the research, you'd still be waiting. So while I contribute programming and live by my theories and my programs, the researchers, it was so funny when Gary said the Beale and Tucker thing, or the Tucker and Beale thing, because he moved me from fourth author, you will note. And that's clearly where I am. So I want to share some of my adventures in community behavioral health. And I'm going to whine occasionally about why is it so freaking hard to help kids and families. They make it so difficult in our world, in our systems. The documentation, the hoops, the rules, it really is difficult. And I'm all about protecting the consumers and the clients, but man, when I started in community behavioral health 23 years ago, it seemed simpler. It really did. You did work, you wrote a note about it, and you went home. And you could feel like you were doing good work. And now, I tell you what, your documentation and your requirements to keep up with everything are becoming a full 50% of the work that we do. And it's frustrating. But, moving on, I'm going to try to identify for you, in my perspective, what are some critical issues that influence adventure therapy in our world today. And I need to apologize up front. I'm U.S.-centric. This is my world, and I'm going to talk about policies and legislation going on here in the United States. I think it infiltrates other places around us, but that's where I come from. Thanks to Anita, I know now I can call it micro, meso, and macro levels. And we'll look at some opportunities that we have there, and what are the barriers? What's going to get in our way as we move forward? Where does adventure therapy fit in? And two of my favorite words that you'll hear me talk about will be intentionality and integration. So, the best thing I can do, in my opinion for you, is to share things that are important to me and how they fit into the world of adventure therapy. Trauma-informed care is a really hot topic, and it's important. We, in our Northeast Ohio community-based mental health center, we estimate that we serve about 90% of our clients are traumatized. And by traumatized, we used to define trauma as physical abuse, sexual abuse, neglect, and maybe emotional abuse if your county or state was good at identifying emotional abuse and doing something about it. But mostly it was the abuses, right? Trauma, we now understand, goes a lot broader and a lot deeper. And so if you only looked at those criteria, less than half of our clients would be in that traumatized category. However, when you start expanding it to being exposed to domestic violence, living with the traumatic stress of guns in your neighborhood and in your home, having people in your family incarcerated, loss of any sort, all these other things contribute now, we understand, to trauma in terms of how it affects the brain, the thinking, the functioning of the individual. So, I'm going to mention briefly the ACE study, and I hope you've already heard about it because I'm going to be brief about it, but if you haven't, Google it because it's got tons of good information for you. ACE study. The Neuroscience of Psychotherapy, thanks to Christine Norton. I said to her, at the last two TAPG gatherings ago, I said, where are you getting your neuroscience information? I need more neuroscience information. She said, try Cozzolini. I did, and boy, do I like him. I think you will too. And he's got some interesting things to say, I think, directly to adventure therapists. And then finally, trauma and providers. I don't want to lose sight of us. in the midst of all this trauma, because there's an effect there. So, first, the ACE study. This is their classic slide. This is the ACE study, and the ACE stands for Adverse Childhood Experiences, and so it talks about all those traumas that people have. It was a giant study out of Kaiser Permanente. They had over 17,000 participants, and all they did was answer a survey, voluntarily answered a survey about those things I just mentioned, about all those trauma points. Did you have any of these occur to you? Yes or no? No intensity, no duration, nothing, no depth to this survey, frankly. We would probably say, oh, this isn't good enough, and throw it away at this point. But back then, it went through, 17,000 people answered it, and they got a score of 1 to 10 in trauma. And then, whether they had scores in trauma were really clearly related to what were their behavioral and physical health problems going into the future. And so let me walk you through this triangle just real quickly. You have an adverse childhood experience. If you have a 0 or a 1, you're probably not going to have disruptive neurodevelopment. But once you start racking them up, and trauma begets trauma, okay? So people who are in homes, children who are in homes where they're exposed to domestic violence are likely to also see substance abuse, loss from separation or divorce, people in your family with their own mental health disorders, and then the abuse and neglect that is concurrent with many of those sorts of things. So it disrupts your neurodevelopment, and while I love this topic and will talk to you about it for the next 3 or 4 hours, I won't. Just trust me, it disrupts their neurodevelopment, which means they don't think or react or respond in what we consider to be a normative or healthy fashion. When it's disruptive, they have impairment in social, emotional, and cognitive ways. Isn't that where we were? Okay, so social, emotional, cognitive stuff. It impairs what happens to them, how they make decisions, and how they function. Children with disruptive neurodevelopment look more impulsive, more aggressive than other kids. Okay, and that's a hallmark, but it's also, of course, a hallmark of several diagnoses. And one of the trials in our field right now, if you're an assessor of any sort, is how do you weed out trauma from ADHD, trauma from ODD, trauma from so many other things. How do we figure out what's what and what are we treating? So they have impairment. Because they are impaired in these areas and not making good decisions, they start to adopt risky behaviors, or behaviors that we think aren't healthy. Actually, some of the newest research coming out on this same data is about the fact that these health risk behaviors that are identified are actually survival mechanisms for these kids. Okay? So we label them as bad behaviors or not healthy, okay? And their brain is wired to do those very behaviors to save their lives. And we say, no, that's bad. So it's an interesting conundrum we're in working with these kids. But the problem then is if you have a lot of risky behaviors, whether we label them correctly or incorrectly, you get diseases and disabilities to a much, much greater proportion than other people. When I first came across this study about 7 or 8 years ago, I'll say, I would go through this, boom, 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 all my points when I would talk to people. And then I get to this one and say, and if you have all these diseases and problems, you're likely to die earlier. What I've done a little more deeply, just in the last couple of years, we're not talking a couple of years. We're talking anywhere from 12 to 25 years early. 2.5 decades. Why? Because they suffered abuse and neglect when they were 3 and 4 years old? Yes. This is how it plays out in people's lives unchecked, unassisted, untreated. That slide changed my life, and it changed how I viewed the clients that we work with. And it made me crave more information about neuroscience. And what do we do? I clearly understood why their brain gets rewired and how it functions differently. But what can we do about that? I didn't know if challenges and activities and hiking and camping would do anything for that. So I started dipping into the brain research. Brain research is the next, it's the current big thing. It's not the next big thing. It's the current big thing. There are over 52 different departments in the government, mostly under the National Institute of Health. 52 different departments and divisions doing independent brain research. And they're not talking together so much. We have so much information out there, and if we could, they need like a giant Bobbi Beale to facilitate them all. That's right. Honestly, they do. They need to get all together, and they need to make this information available to us because it's interesting, it's helpful, it's current, and it's real. But as a therapist, as a provider in the field, this is the book for you. It's I almost want to say easy reading.
Yeah.
Okay, thank you. I don't want to overly challenge somebody, but I want to say it's kind of easy reading. It gives you really nice perspective on what therapy does to the brain. It brings all the current research in. As a matter of fact, one of my favorite things about this book is a full 25% of the book, 100 pages, is references and resources. Okay, so it's not quite as big as you think it is, but it's a textbook for sure. But I'm enjoying it, getting through it. And I want to point out these critical factors. Get out of that light for a second. Okay, so critical factors that Cozzolino identifies in psychotherapy. And I want you to think about adventure therapy while we go through these critical factors, and whether we're good at these things or not good at these things, whether we address them at all. Number one, the relationship. There's so much written about the relationship. We understand that the relationship is the most clearly identified change agent in therapy, okay? But what do you think? Adventure therapy. How are we at having relationships with people? You're freaking awesome! You have great relationships with people. They like you, they're engaged, they're less resistant to our treatments because we have fun and we do things actively with them, blah, 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 blah. You know this. Don't be in here. You're really good at this part, okay? Relationships are good. We need to pay, but we shouldn't just accidentally be good at relationships. We need to pay attention to them. You need to be intentional about your relationships with your clients because it is the change agent. Optimal stress. Now this is okay, this is a current and ongoing perennial debate in our field about this concept of stress. So I want to encourage you just to sort of smooth that debate over for a moment to think of this as arousal as opposed to stress. Think of it as arousal, and there's an optimal level of arousal. And so if I could draw an inverted U here, those are arousal states, from low arousal up to an optimal arousal and then back down. And what we want is for people to be at an optimal arousal. When they pass optimal arousal, that's when their neural dysfunction kicks in and they cut off. They can't think, process, problem solve, or access their frontal cortex at all. Okay? So our job is not to shove them off the cliff and say, it'll be good for you. You'll feel better afterwards. Our job is to help them be in an optimal level of arousal. If you're not aroused at all, if you are sleeping in here, you're not learning, you're not engaging, you're not taking anything in. Okay? And so students have to be at an optimal level of arousal to learn in the classroom. Clients who work with us have to be at an optimal level of arousal to make progress in treatment. So we have to think about optimal stress, optimal arousal. But I definitely think we've been paying attention to this one. Okay? And we still need to pay attention to it. The activation of both affect and cognition. Well, the model, the adventure therapy model, actually adds one more component. What is it? Behavior. It just gets better for us. Okay? They want to make sure that if you're sitting in an office with somebody, you are not simply paying attention to emotion and not paying attention to thought processes and all the things that we know are important now given all of our CBT information. And by the same time, you cannot just be heady and clinical about things and not engage people emotionally, because it won't stick. It doesn't stay with them. The things that make our behaviors activate is how we feel about them. Okay? So we really need all three: affect, cognition, and the behaviors. And again, I think we're onto that. Finally, a co-construction of narratives. So clients come to us and they have this history of trauma, perhaps, or they don't. They're worried well and they have some issues that they'd like some assistance with. And together, we try to figure out what skills and behaviors do they need to manage and cope with what's going on in their life, and then address the problems, and together rewriting and identifying their own history, even their own trauma, reintegrates that information in their brains and heals those disruptive neural pathways. That was so simplistic. But Anita said that's what I'm good at, so that's what you get. All right. The bottom line for this slide is, it's a good book. You can get through it even if you're not a neuroscientist. And it will help you be more intentional in your work doing adventure therapy. I'm not trying to convince you to be a neuroscientist. I'm trying to convince you to be an informed practitioner. And this is the current information. You can find other books. I don't care. I just want to give you an example or a sample that you could use. Okay. Oh, this is Paxton. He's my 2-year-old. I shamelessly just put his picture in there. Shamelessly. But here he is. You have to be a superhero. You have to be a superhero to do this work. That's my excuse for having that thing. All right. Okay, so let's talk about providers for a minute. Providers, therapists, case managers, rec leaders, all these people. We are exposed to what's called secondary trauma. When you hear your clients talking about the traumas that they've experienced, the things that have happened in their lives, it can be stressful. It begins to affect your neurobiology. It definitely affects you emotionally, okay? And trying to be calm, cool, and collected and have no reaction, you know, maybe you can pull that off temporarily, but don't kid yourself. You're integrating that into your being, okay? And so secondary trauma cannot be ignored. And you are, if you're working with anywhere near the population that we're working with, in general outpatient behavioral health, then you're being exposed to secondary trauma, and you just need to be aware of this and do something to take care of yourself. There are many things you can do to take care of yourself, and we'll talk about that in a minute. But just be aware that you are. Now let's think about the trauma rate and its implications. Okay? So, what percentage of people experience childhood trauma to the point where they make it onto that pyramid? I'm thinking, because I didn't have that slide up there. I want to say, oh man, anybody know? 25% of kids annually. 25% of kids annually in the United States are exposed to trauma. Okay, so there's kids right there, but then a lifetime accumulation as you go on. In that particular study, I want to say that 60% had a score of 4 or more. But I might be a little high on that. At any rate, think about these numbers. Where do you get your staff? Think they might be traumatized? Think some people go into the field to correct early life experiences? Think they might get re-traumatized when they listen to the clients and the kids talk about the trauma? These are all just critical issues. And it's one of those things, in our race to be trauma-informed, and trust me, my agency's racing to be trauma-informed, I think we're overlooking the effect of all, even trauma trainings on our providers. I do about a half day trauma training with all 160 employees, 25 people. And virtually every class, somebody's saying, oh my God, my score on the ACE study. And I'm coaching them in between, on the breaks and things, that you're okay, and look how far you've come, and you're clearly resilient, and those sorts of things. But I think we have to be more careful about this. We need to be aware. And if either you're working in the field and exposed to secondary trauma, or you're supervising staff or students who are doing this, we need to address this, and it needs to be directly. And one of the ways to do this is to take time in your supervision to do supportive, empathic supervision. Now, this is tough, because remember when I opened up and said, my God, they make it so hard to do work anymore. I have to do all this paperwork. I have 8 supervisees on my license who each have between 10 and 50 cases. We have a lot of casework to look at, and the documentation is never ending. When exactly can I sit there and gently and supportively say, so, how do you feel? How's this affecting? I tell you, you better be doing it every damn week. Okay? Because if you're not, this is where they're going to burn out. This is where they're going to have bad reactions to their clients. This is where they're not going to make the right decisions because their trauma has crept up into their brains again, and it's going to interfere with the work. We must do things to support our staff, and it's the best way I can think of is through supervision. I'm open to other ideas. Your turn. Okay, so just where you are at your tables, I've set out a list of questions here. Do you serve people with trauma? Is your organization or program trauma informed? Do you even know what that means? What would that include? Do you provide or receive trauma informed care training? And do you provide or receive supportive supervision? That's my big clinical issue. This is on the micro level. This is about the clients, okay? So this is the micro level part of the talk. I'd like you to just turn into your table or to whoever's near you to talk. Pick a question, or if you can't relate to this theme or topic, is there some other clinical issue that's come to the forefront for you that you think we should be paying attention to? I'm going to give you 5 minutes to chat at your table. Please try to let everybody say something. Shout out to the rest of the room from your table. What theme did you get onto? Do you have any ideas? Does anything strike a chord with you? Do you think adventure therapy is particularly good at any particular part of this, that sort of thing? Yes?
We were talking about how hard it is to come forward and say that we're having a hard time with this because we don't want to look like we don't know what we're doing or like we're not being professional enough to handle these things. So that ends up being something that has to become part of the culture, and it has to be okay, and people that especially are in charge have to make that effort to step forward and check in and say, you need to talk.
Mm-hmm. Thanks, Mary. Agreed. Somebody else?
We talked about the difference between effective supervision and non-effective supervision, and what the experience has been like in the various programs and companies that they've worked for, which is really interesting.
And is there a hallmark of effective supervision in your opinion?
For my personal opinion?
Or your table?
Table?
It's okay, I just wondered if you were saying effective supervision has this, non-effective supervision has that. If you don't have that articulated, that's okay.
In my experience, because the table is falling silent at the current moment,
I don't know how that happens.
I think that it should be consistent. I think that the supervisor needs to be trained on doing supervision. And I think
no way. Does this come to you when you get supervisees?
No, it's not like different. Yeah, I think in my studies here at Prescott, I've been looking at decision making and cognitive errors that occur and decision-making flaws that happen with, as you gain more experience of being a field instructor. And it's interesting because I think in my experience, supervision sort of gets watered down as you gain more experience, and there's a mismatch there that needs to be done.
Okay. Anybody else? Yes?
I feel like as a supervisor, I'm much more supportive to my staff that use the supervision like in a good way. So like the ones that like come to me and bring it to me, like I feel like then I'm a very effective supervisor. But I feel like for the ones that aren't as apt to do that, I'm not doing that as well. So that's a good reminder.
So it's a challenge to us, just like it's a challenge that I'm so far into the parallel process. So I should go with Manus. Just like it's a challenge in a group to bring out those participants who are a little reticent to share, we need to reach out to our supervisees and say, it's okay, this is a safe space, what do you need? And that is a cultural shift. That can be a cultural shift. One of the things we were talking about back in the corner is, you know, some of the most toxic places in the world, in my opinion, are social service agencies and academia. They can be great, can't they? They can be. But they can also be horribly toxic with infighting and blaming and not taking care of yourself and not sharing appropriately and all sorts of things. So we need to change that culture. But it has to come from the top down. If you look at implementation research and how you implement new practices and evidence-based practices, you must have buy-in from the top down or it's never going to be successful. All right, I'm going to move on. Keeping an eye on the time here. Next, I want to talk about evidence-based programs. So, if you know me, you've heard me talk about this for the entire decade that I've been working with this group. And evidence-based programs, there is an unreasonable cost associated with evidence-based programs. Whose evidence is it anyway? What about fidelity? And how about evidence-based components? So, implementation money. Evidence-based programs become franchises. Evidence-based programs is, on the face value, it's fabulous, isn't it? Let's get some evidence behind some programs or techniques that are truly effective with specific populations or problems. No brainer. I'm in. Except you're not in unless you can afford to be in. Okay? Evidence-based become franchises because if we produce an evidence-based program, it's very competitive. And when you can get yourself listed with NREP or something else, then not only do you have a right to, in our capitalist society, to turn around and charge people to get your information, you have an obligation that the federal government puts on you to be able to disseminate, consult, train, and help your evidence-based program get used. But it all comes with a very steep ticket. It costs money for the training. It costs money for the consultation ongoing, and many of them have ongoing consultation requirements, not just helpfulness. And it sometimes costs money to continue contributing to their database. And so you have to use their tools and send them into them and those sorts of things. It leaves providers and consumers in a very well-intentioned system that can't ever be sustained. I work in, as I told you, sort of a mid-sized organization. If we were to train 8 providers, only 8, but we pick 8 top-shelf clinicians to learn a half dozen evidence-based programs for kids, because I'm in a kids and family environment. A half dozen. The price tag on that, pick any 6, the price tag on that is $250,000. $250,000 to train seasoned clinicians to do evidence-based programs that may or may not already be part of the work that they do. And half of them are going to leave in 3 years. So I have to keep repeating that price tag. Do we have that kind of money in community behavioral health? No, we do not. I don't know where you work, but I'm guessing you're not sitting on $250,000 either. Okay? So that's my bitch about. But I didn't say it was my only. So, federally funded or supported research. So many of those evidence-based programs get federal funds to do extended research to meet the gold standard criteria of research so that they can get listed as an evidence-based program. Who pays for that? You do. Who pays for that? Your customers, consumers, and clients pay for that. So we're paying for the work to be done through our taxes, through our healthcare system, through our federal government, and then it's privately disseminated. Then they own it and get to sell it back to us. I'm having trouble. Who's double dipping? That's a big evil word in my business. Double dipping. Have you billed twice on the same client? Have you overlapped for that 30 seconds? I mean, it's all about that double dipping, and it's no good. You're not allowed to do that. And I'm saying, who's double dipping into the taxpayers' pockets? So, a couple of weeks ago, I was in Las Vegas at a conference, National Council of Behavioral Healthcare Providers. So it's like an association membership for behavioral healthcare organizations like ours. And so that's where I was, sharing that poster over there. Thank you very much. And I met a woman named Kim Hogewood, who works a low-level federal employee. And she did, it's popular now in conferences to have TED Talks. Have you been to a conference where they do TED Talks yet? So she did a little TED Talk where she gave me the statistics on how much it costs you to train half a dozen employees and a half a dozen things. And the upshot of her provocative TED Talk was, we should be giving it away. Once it's a proven thing, it should be published and disseminated for free. You should have access to it. We've already paid for it. But the worry in our capitalist society is that nobody will develop programs if they have to give them away and can't make money off of them. First of all, I'm not convinced that they're all that greedy. We're lockstepped in a system that makes us do that sort of thing right now. Okay? And secondly, she had a follow-up idea, which was something we've talked about for many years in REAP, and that is a data depository, where your payback is that you do have to keep collecting outcomes and whatever tools are used for that particular program and get it back in so that they can keep learning and growing and modifying the program. Modifying. Oops. Did I say that? That's not fidelity. We'll get to that in a minute. Fidelity and the evidence-based components. So, yeah. I'm not sure what's so funny out there, but okay. Is the picture? Okay, thanks. All right. So, is being unfaithful to fidelity really a sin? What do you think?
No.
No? Anybody agree or disagree with that? What do you think? Fidelity programs, evidence-based programs.
No. Can't throw your assessment skills out the window.
Okay. Don't throw.
Individualized anyway, so how do you... There's some good research that says really, really good seasoned clinicians do changes to evidence-based practice with quality. And that's a real tricky thing because the better you are, the more likely you're not to be, in terms of adherence to a model. So the really competent ones are competent with fidelity, but might discharge or go norming away from the adherence because they know better.
So, one of the big complaints about evidence-based programming over the course of the last decade, which is when evidence-based programming arrived on the scene. I mean, you know that before 1995, you couldn't find those words. And so we're really talking about less than 20 years here. Was that their cookbook implementation, they're scripted. You have to do everything exactly as the developer, the originator, planned it. And if you don't, you're not adhering to the program, and they can boot you out of the program, or you're not going to have the same level of effectiveness, that sort of thing. And clinicians riled against that. They said, "What? I know I'm supposed to be the practitioner scientist, but I'm a practitioner, and that means I practice and work it out with whoever I'm working with. And why are we lockstepping ourselves into these things?" So, in another TED Talk at the National Council, I heard a guy named Anthony Salerno. Now, I didn't really know Anthony very much before this. I'm working on a project with him now, but he he was the head of evidence-based practice dissemination in the state of New York for a decade. And his TED Talk was, is it really a sin to violate fidelity? Because what he said was exactly what Anita was saying, is that if you're really paying attention, if you're a good clinician, and you're trying to do the right things, you naturally and necessarily will adjust things. But you do have to understand what are the important things to adjust. What are the things that are available for flexibility that won't compromise your ability to get the results that the evidence-based program touts? And that's tricky. I don't think you can pop out of graduate school and do that, frankly. Okay? And no insult to students. I swear the doc interns who come into me every year are smarter than me as they start rolling through with all this information. But I don't think that they're skilled experientially. I don't think they're skilled in their relationship and their alliance with clients because they just haven't been doing it as long. Okay? So this is tricky. It's almost slippery slope-ish, but I think we have to pay attention to it. After 10 years of implementation, he was saying you should alter things based on your population, based on the intensity of the symptomology, you can alter the speed of how you're going through the program. All sorts of things can be tampered with, if you will, and to the point where it's more effective, not less effective than the evidence-based program. Then I want to say something about evidence-based components. A few years ago, we brought in, oh my goodness. Anybody remember the guy's name on the kernels? Thank you, Dennis Embry. I can only think of his buddy, Anthony Big one. Dennis Embry came in and talked to us at a REAP symposium about evidence-based kernels. And he identified all sorts of very small interventions or nuggets. I mean, literally, teeny little kernels like flipping the lights instead of screaming, be quiet. Okay? Little things that have evidence behind them. They're parts of research all over the place about them, and said if you can use evidence-based components, you're really doing stuff that is evidence-supported. It is not an entire... You don't just become an evidence-based program because you use a half dozen evidence-based components or kernels, but you're still evidence-supported in what you do. What we need to understand is not all components are equally important. I worked with a woman, Lynn McDonald, out of Wisconsin, I think, and she had a program called FAST, Families and Schools Together. This is an evidence-based program listed on NREP. And we ran FAST for several series. You do it a semester at a time in a local elementary school. The problem was we could serve 8 to 10 families, and the program was about 10 weeks long, and it cost $25,000 per run. That's a lot of money, but that's how expensive evidence-based programming is. And it was great. It was effective. The families were engaged, all that sort of stuff. What I really appreciated about Lynn McDonald was in her manuals, she identifies, stick with this, do what you want with this. This is where you can alter the program. This is where you have flexibility. This is where you want to meet your clients where they're at. And it was, I really haven't seen other evidence-based models who are so blatant about that until I met Tony, who said you can do that with all the programs, just don't tell them. So, if you go on NREP, and a half dozen other places that list evidence-based or evidence-supported programs right now, there are between 400 and 600 evidence-based programs for kids and families. That's a lot of programs out there. If you do sort of a meta-analysis of these programs, I'm not sure if that's the right word, you researchers in the crowd, but if you look at them all and disseminate their components, there are between 40 and 60 common components across all programs. That's what we need. That's what we need to know. And I'm going to find that list for you if it kills me. But I don't have it yet in my hands. They're talking about it, but they're not giving it out. As a matter of fact, there's a guy out in Hawaii, Bruce Chaprita. Anybody know that name? Blue something? Blue?
The Blue Menu.
The Blue Menu? Mm-hmm. He's got a project where he's doing this dissemination project to find these core components, but he'd like to sell it to us. already, so it's frustrating. But there are 40 to 60 common elements. For instance, if you've ever, how many people have done parent training or parent education or parent behavior management, that sort of thing? There are really simple components to that. And they are in every parenting program that is worth anything. Okay? And it's not hard to have a worthwhile parenting program, frankly. The number one thing is improve your relationship with your kid. And if they're good, they do that first. Okay? Because you can't discipline outside of a good relationship. And then the number two thing is learn the skills of being an authoritative parent. Kids need boundaries. Kids need support. Kids need to know what's what. And they're in PCIT, parent-child interaction therapy. They're in the incredible years, early year parent training. They're in Barkley stuff. They're everywhere. Those are the two key and important components if you're going to work with parents and families. And wouldn't it be nice to sort through all that rubbish? Oh, I shouldn't call it rubbish. Sorry. Wouldn't it be nice to sort through all those other elements and components and say, these are the two big things with parenting? Let's stay focused on that, because you would make a lot of progress that way. So fidelity, evidence-based components. We need to find out what components we align with. What are we good at? What can we help out with? Oh, it's an activity. Let's engage your brain. Let's engage your brain for a minute and do a little activity called Have You Ever? You may or may not have played this. People familiar with Have You Ever? Yes. Okay. Find a partner, and here's how it works. Pick, I don't care, the tallest person can go first. Pantomime doing something. Okay, brushing your hair, doing whatever you want. Try to make it legal and clean is what I have to tell the teenagers, and I'm guessing I have to tell it to you. Okay. Pantomime some activity, and they're going to ask you what you're doing. When they ask you, and this is the hard part because it engages both sides of your brain, you have to say something different. So if I'm pantomime and combing my hair, and Jason asked me,
what do you got?
Brushing my teeth. It's amazingly difficult to do until you try this, okay? So as soon as I say brushing my teeth, he has to do what I said. I get to stop doing what I'm doing. I give him a second, and I say, what you doing?
My car.
Driving my car. So this engages your brain laterally. And I just want to stir up your brains a little bit so we can move into this next part, which is a little more boring. I know. All right, feeling a little more energized there? I hope so. You look like you were having a good time. I sure enjoyed watching you. And I was corrected. Of course, that was not called Have You Ever? That's called What You Doing. Yes.
Have you ever?
That's true. That's true. It's a meta activity.
Wow. You were just modeling.
That was good, Mike.
Before you go into federal influences,
please.
Could you explain what you meant by engaging the brain laterally? Engaging the brain laterally.
Say it again backwards.
Well, we process different things on different sides of our brain. You're going to stretch me here as a neuroscientist, but so more motor activity is processed on one side than verbal activity, and you have to, if you're performing a motor activity but talking about something different, you are forcing your brain to communicate across hemispheres.
The advantages to that when we're working with students?
The advantages to that when working with students is, well, it goes into problem solving and being able to access both kinesthetic and cognitive solutions to things. Thinking outside of the box, you can't do that if you can't cross-laterally think.
Enhancing the whole.
Anybody else want to add to that? Because I'm not an expert on any one part of this. This is information that overwhelms me on a daily basis that I have to try to make sense of. So I'm trying to interpret it for you as well.
And I appreciate the simplicity of your responses. They're great.
Okay, thanks. So let's move on to the simplicity of the federal government.
Right past that slide.
Okay. These are things, I picked just a couple of highlights because I want to tell you there's dozens of ways that the federal government is influencing business as usual at CNA. And I'm likely thinking they're influencing you. But these are some things that we're paying very close attention to. At the top of the list is parity. Are you aware that parity passed? And that's a great thing. Okay? So parity was a bill introduced by Senator Patrick Kennedy at the time. And he is both an advocate of behavioral health services and a passionate promoter of brain research and bringing the 52 different departments together. He was inspirational to listen to at the conference. He was one of their keynote speakers. And I did not relate him to parity before this, and so I just thought that was kind of interesting. I'll tell you a little funny story about Patrick Kennedy. So he is not, he's definitely a Kennedy, and his oratorical skills were phenomenal. And so it was fun just to sit there and listen to him. But he was backstage with the head of that organization, Linda Rosenberg, and she was saying, well, I'm getting ahead of myself. Patrick Kennedy has been in and out of rehab several times, suffers with major depression, and is himself a consumer of mental health services, and is a tireless advocate for those consumers. So he's backstage with Linda, and she says, Patrick, I'm so glad you're here. You're a rock star. And he says, in my family, I'm not a rock star. He was such a forthcoming guy. To be that high up in the public eye and to be willing to share some of the things that he did with that broad audience, it was inspiring. So, parity, yay. Here comes the integration of physical and behavioral health care. What does that mean to us? Are you aware? How many people feel like they're up to date on the integration of physical and behavioral health care? Anybody? Oh, hell. Okay, here we go. Health homes are going to be one of the answers to the integration. I'm going to tell you a little bit about those. And the value of collaborations. Here we go. Okay, integration. First of all, integration ties back into the ACE study. Having behavioral health concerns in childhood is an absolute precursor to physical health problems in later life. It's a direct link. Okay? So, when we're serving these kids in behavioral health ways, are there things that we could be doing that would assist them, that would educate them, that would put them on a path of wellness, not just about their social emotional skills, but their physical health? And of course, there must be things that we can do. So this all ties back into the ACE study, which I find interesting. There are many more. There are other studies, but none as pivotal as the ACE study that launched us into this. What's going to happen with the integration of behavioral and physical health care? It starts with parity, and it says you can no longer treat physical health care like this and behavioral health care like that. One of the things that Patrick Kennedy said was, if we treated diabetes like we treat behavioral health care, you couldn't access services until you amputated your leg. Okay? That is how hard it is to get behavioral health care services. But parity leveled the playing field. It's not perfect yet, but it is definitely on its way to being a more equitable system. I think it's going to invite more holistic practices. We have to look at the whole person. And haven't we always wanted to do that? I mean, isn't that feels like us? Okay? We like having an eye on the whole person. But in very concrete ways, we're going to have to be aware of the whole person. There's going to be sincere efforts to bring down the silos. And do you know what I mean when I say the silos?
The separation.
The separations. Like the 52 parts of the brain research and the difference between the Institute of Health and the Institute of Mental Health. And education's over here. And juvenile justice is out there somewhere. And these are all silos in political lingo. And we must communicate better together, because Our kids are in all of them, but we pretend like we only have to deal with this one. Okay? So there's going to be efforts to bring down the silos. Is there a lesson here for adventure therapy?
Yeah.
A little parallel process again. Okay? And I just want to encourage us. It's time to step away from our internal differences and step out to the world and show them what we have to offer, all of us. Adventure therapists, wilderness therapists, rec leaders. Remember, holistic. We're all needed. There's work for everyone. There's no need to be competitive or judgmental across our own divisions. It's just unnecessary any longer. You need some of that internal conflict as you come to grow up, as you evolve through your adolescence. It's time for us to grow up and to go out and meet the rest of the world. What are the opportunities in this? Well, I'm going to mention two things, and one is research, because you wouldn't go very long without hearing me talk about research. And if we're thinking about research, and you should be thinking about research or at least outcome data, we should probably be thinking about biometric things. We should be thinking about how to include things to monitor with our clients and our consumers to go along with our behavioral ratings and our group norms and our things like that. Because what we do can have a positive physical health impact, but we're not measuring it. Okay? And we have to start thinking about how does the whole person respond to my treatment, not just how does their relational skills respond to my treatment. Okay? So think about that. And yes?
Sorry to interrupt. Can you give an example of a measure or something that we might measure biometrically?
I'm so glad you asked.
Yeah.
Height and weight are a good thing. Denise Minton, what's the thing?
Hip-waist ratio.
A hip-waist ratio is something that tells you a lot about what your future health. We're thinking about using in our day treatment program. I don't know this yet, but we're thinking about using in our day treatment program a swab, a mouth swab that measures stress hormones. There's lots of stuff out there. I'm glad you asked because I think that this is the point that immobilizes people. They think, yeah, this is cool, I should help, I should do something, I don't know what to do, I don't know what tool. Give me the perfect tool. And there's no such thing as a singular perfect tool for our field or for anything. It's more important that you just pick something and use it. Okay? Pick something and use it. Now, there are people to consult with here. I don't ignore your colleagues. You can ask them, I'm looking at this, what do you think? What concurrently could I look at? Or what kind of tools have you heard about? Or, even better, do a little research first. Look into what studies similar to what you're thinking about, what have they used? Because then you're going to have comparative data. Okay? So, pick a tool and go. Social justice. I think this idea of breaking down the silos and looking at the whole person and parity for people with very stigmatized disorders, which are all mental health disorders, is really going to move us towards social justice. And again, I feel like that's us. That's us. That has long been a part of AEE's values and mission. Health homes are one way, one part of integrated physical and behavioral health. And there's a paper that was put out by SAMHSA in January on health homes. And if you're interested, it is, it's like 70 pages, but it does have a 8-page executive summary up front, and it tells you about these sorts of things. And if you're interested, you're welcome to shoot me an email and I'll send it to you. But I want to say two things about it. One is there are models for integrated care. And I want you to hear this because think about where do you fit in? Because you're going to have to fit in. If everything integrates, that means us. We're going to integrate. Okay? So, there are 3 levels of health homes. One is a facilitated referral model. This is closest to what we're probably already doing. You exist in a community somewhere. Your program, your organization, your agency exists somewhere. And you, hopefully, I assume you're doing this if you're viable at all, you have relationships with people who might refer to your program. Maybe with educational institutions, maybe with social service, maybe with court, maybe with whoever your referral source you think comes primarily from, you probably have relationships because relationships lead to referral, okay? Networking. And networking, by the way, is one of the things we do best. We could share that. Secondly, another model is co-located model. And that means that you link up with somebody who does some other part of services. So for instance, child and adolescence has a very small community health clinic, physical health clinic, in one of our hallways, in one of the buildings that we use. So we have already talked to them about integrating services with them so that we are co-working on similar cases with them. And do their kids need behavioral health stuff? And do our kids need physical health and wellness checks? And working those relationships out now. And then there's the in-house model where you bring everything together. Now that typically happens in metropolitan areas in big hospitals who are going to bring social services inside, they're going to bring educational consultants inside, they're going to bring all sorts of things right inside so that they are a full service stop. That's the most ambitious of the models. But I think we're probably going to end up here in the first two. And I want you to think about who do you have relationships with, because you want to strengthen those relationships, because this is going to be here before we even know it. Collaboration is essential. These are the 5 key points identified by SAMHSA as being ready for integrated care, being a part of integrated care. These are the things you have to understand and be supportive of. First of all, it's family and youth guided. That they are considered part of the treatment team. They may never be excluded. You can't meet without them. They are the experts on their own lives. We give a lot of lip service to that sort of thing, but we don't always toe the line and make sure that they're completely involved. So that's something that's just going to be more and more happening. Individually, but coordinated care plans. So everybody has an individual plan, but it's coordinated across all the services and systems they might need. And let's think about this. We have physical health care, we have behavioral health care, we have dental care, we have eye care, we have education, we have social services. I mean, all these things need to be coordinated. One of the things they're going to say is that you need to have evidence-based guidelines. Whatever you're doing, there are places piloting this already, and you want to be in line with evidence-based guidelines. Now, I don't mind the fact that they say evidence-based guidelines. Guidelines are not mandated scripts. But what they are is they're saying, are you doing the things that get this family or this kid all the services they need? And some of the strictest evidence-based requirements are going to be around assessment. Because assessment's going to be critical. When a kid comes in, you're going to be asked to identify all sorts of things, not just your specialty. Okay? So assessment, screening, and, thank goodness, well-child visits. Because what happens a lot of times with our population and why they have poor health outcomes in the long run is they're so busy trying to manage the behavioral health and trauma issues that they don't pay attention to nutrition and health in general, and that leads to bad habits and later problems. Okay, so we want them to start getting education and well visits right from the beginning. You have to have relationships with other entities. At CNA, we're talking with both local hospitals about, can we be your partner in this federal stuff? You know, what do you need from us? What can we get from you, sort of thing? You need people who are politically savvy and social networkers. You need people who can go out and do this collaborative work. And I know, and I warned you, didn't I, that this was the boring part, and I can see you starting to glaze over here. That's because we'd all rather be in the woods, right? But if you want to keep serving kids in the woods, somebody's got to take care of business. And we're part of this business. And finally, data-informed planning. So everybody's into the data. You're going to have to keep outcomes on what's going on, and I would suggest that you keep outcomes and think about both sides of the coin, physical and behavioral health. All right, let me push through. I want to say we're skipping it. Don't get to talk.
11:44.
Oh, is that a little fast?
Yes. Yeah.
Good. Well, your tabletop discussion would have at least think here. How do you feel about holistic practice? Where do your referrals come from? What about your organization? I am going to skip this because I have more things that I want to get to finish up. So, where does adventure therapy fit in? Where can we go? What is our niche? I hear people talking about niche all the time. Or niche. I'm not even fancy about it. But that's what I hear talking about all the time. What's our niche? And by that, I'm asking, what's our differential value? What makes us the right answer for some things? What is it that we do that's special, that's different, that's effective? And if you're struggling to articulate an answer, you need to find one. You need to be able to say to people, this is why we're effective. People will say to me, why? Why do you think your groups are so effective? Why were your outcomes good? And I will look them in the eye and say, experiential work is the way to go with kids. It engages them on so many levels. In addition, we give them that in vivo opportunity to rehearse the skills. Not just talk about them, rehearse them. With peer and adult feedback. Then we have pointed performance coaching, so adults can interfere with behaviors going awry and say, hold on, can you make another choice? Can you do something differently? Firing those neural networks. Rebuilding neural pathways that they lost through trauma. I can say those things. I know them to be true. I have experience and I have data. You need to be able to articulate what you do and why it is valuable. Thank you. So, who are we? Think about that. Who are you? What's your part in the bigger circle of adventure therapy, and what do you do here? How can we be renegades and yet integrate with everybody else? This is a history that we have and share, that we were the outliers. We were the ones who had disdain for the office and wanted to be out in the field, and we would prefer to do all of our work in nature, which is a great healing place in and of itself, and that's all still true. I want to tell you that you do not have to let go of either your history or your love of your locations for doing your work. But we still have to figure out how to integrate and how to offer that up to the bigger healthcare system that is slowly merging, because we have plenty to offer. So much to offer that I'm going to tell you we should reject the niche. We are not a niche therapy. We are not something that only works with this amount of the population. One of the things I love most about adventure therapy is its plasticity. Okay? I love to say I can take any activity, almost any activity, and work on any clinical theme. What's really hard to come up with a cookbook for adventure therapy, it's really hard because I can manipulate the theme around the activity. So I could say, what do you think the best activity is to teach couples communication? And we could get 20 different answers here. But pardon me? Yeah, and I heard that yesterday. It's true. That's probably why that example stuck in my head. But I'm going to tell you that I could work on couples therapy communication playing Una. I could work on couples therapy communication doing any one of 100 adventure activities.
What you doing?
What you doing? Yeah. Okay? And so that plasticity is both our strength and our point of confusion for some people. Because we can't authoritatively say, this is the answer. Because there's lots of answers. Okay? So, but that is such a good thing. Oh, there he is again. Hi, Pax. Everybody needs a helper. Everybody needs a sidekick. That's why that picture's there. That's my excuse for that one, okay? Okay. So, I think that adventure therapy can offer not just a niche for behaviorally disordered at-risk kids, but a continuum of services. At Child and Adolescence, we have and are building a continuum of adventure therapy services. Is Jen still in here somewhere? At Santa Fe Mountain Center, there's a continuum of mental health services. Okay? So we have a day treatment program where they're academically and behaviorally and emotionally challenged, and all of their group therapy now is experientially based in adventure therapy. And these kids are at the end of the continuum. We're the end of the road in our community, is that day treatment program. Okay? If you can't get help there, you're probably going to residential. And we only send about 1 or 2 kids per year to residential out of our community. Okay? We're all about bringing them back in. Up from that, all our adventure therapy groups where that research comes from. Kids with behavior and emotional dysregulation problems, great. We do great work with them. They range from a little to a lot of problems. Then I just ran last spring a training series for any family therapists in the agency who wanted to do family adventure therapy. And I had about a dozen takers, and now they're out there doing activities with families in our organization. And we do activities during staff training, and we do and so do we have to be this little niche? I don't think so. I think we have things to offer all across the board. Okay? And I want you to think outside of the box about adventure therapy and its own continuum of services, because that will help us in our integration all across the board. I've already talked about parallel process, so on this slide I threw up words that I like. So you've heard me talk about parallel process. You've heard many people mention intentionality here. I am a huge believer in intentionality. I intend every day. I run through a list of intentions. I intend blah, blah, blah. Okay? I intended that research over there about 10 years ago. I said, I'm going to get something. I'm going to prove that we do something good. And there it is. So you should intend, but you should also be intentional about your practices. It's not enough to just like what you do and do more of it. You need to figure out what about it is so powerful and do more of that. Authenticity. I think we have that as well. You're such a fabulous group of people. And I am renewed every time I'm in an AEE group of any sort. And I talked with no less than 4 or 5 people about this yesterday while we were wandering around that lovely little park lake. And when I come here, I feel like so many parts of me are available. I'm not siloed somewhere where I have to behave this way because it's in this kind of situation. Here, everything's okay. And we all come together to try to do the best we can for the world. And that is just the best place to be. And I want a more just and compassionate world. And I know that's part of AEE's values. And I think if we can help move this forward, that's where this stuff is going. So, we need to do things. We can't just think about it. Intentions are not simply thoughts. Intentions are thoughts followed by action. And I want you to think about what you contribute. We all serve people. Beyond that, what can you contribute? And I have a short list here. Let me give you an example. So the 4 R's, what's it called? Promising. It's one step closer. They're nearly listed. Do you know what I mean? So this is a practice. 4 R's and 2 S's is for families who have children with conduct problems. Not conduct disorder necessarily. Behavior problems. Okay? And the 4 R's and 2 S's are things that you know about. Respect and communication and stress and support and things like that. So it's an evidence-based model that is a 16-week multi-family group model. And I like it. It rings true to me. It has those core components that I recognize from other kinds of programs. And so we were engaged in a virtual learning community with people all across the United States, 17 different organizations implementing this program so they could pick up more data for their NREP application. And in working with the program, though, and using my adventure therapist with the program, we were quickly and easily able to identify where experiential activities would heighten the lesson, the generalization, the ability for people to grasp what was going on. And so I went to that conference a few weeks ago, met with the developers, one of whom was Anthony Salerno, that I spoke about, the other is Mary McKay, and talked with them and said, what do you think? I was trying to follow the damn thing to the letter because that's how I've been beaten into shape by evidence-based programs. But when I spoke with them, they were like, no, try your stuff. And if your stuff is working, can you put it on our website so other people can try it too? It's a new breed of evidence-based programmers. And I'm loving it. I'm loving it. So we are now taking this program, going through all 16 weeks, and identifying activities that would lend themselves to those lessons. Then I'm going to offer training to all our school-based providers so that they can engage families who just want you to fix their kid at the school. We'll see how that goes. I'll give you an update next year. Case studies. We have a call out right now for case studies. Write a single case study. Who should we send it to, Mike? To Mike. Write a single case study. We'd like to tie it in with the TAPG website. We'd like to tie it in with the work Mike's doing all over the country promoting adventure therapy programs and helping us integrate into this federal structure. Write a case study. If you're thinking, I don't know, how could I help? I'm not a researcher. I'm just a provider. Write a case study. Okay? It's an easy way for you to contribute. Do some data collection. Pick some data points and collect them. It doesn't have to be rocket science. When we were forced to use Ohio scales as mandated by the state of Ohio, it worked out for us. It wasn't the perfect adventure therapy tool, but it was a great tool to monitor outpatient kid symptoms. And it worked pretty well for us. Get trauma informed. We had the trauma discussion earlier. If you do not feel like you were up on everything that I was saying here, go get some trauma training because it will help your services improve. Infiltrate your field. So, if you have presented anything about adventure therapy at any other organization besides AEE, please stand up. Yay. Who have we presented to?
You presented.
Mary?
Trauma experts at the National Institute of Trauma.
National Institute of Trauma. Thank you.
The All Ohio Counselors Conference.
Ohio Counselors Association.
Consulting clinicians that work with kids coming out of wilderness.
Okay. Excellent. Tony?
School social workers.
School social workers. Mike? So many places it's hard to list them.
APA.
APA. That is a big nugget, isn't it?
Big.
Yes. Northern Illinois University's Counseling Association.
Counseling Association.
CSWA and the Family Preservation Institute.
Perfect.
NASW.
NASW. I was just talking to somebody about that.
Asia AE.
Asia AEE. Okay, you get credit for that one for sure.
Virginia graduate students.
Perfect.
Local DHS offices.
Oh, I like that one.
Ignite Boulder.
What is it?
Ignite Boulder.
Ignite Boulder. What is Ignite Boulder?
Like a head pop.
Okay. Excellent.
It's
So
very
an
good. I
audience.
posted it on Facebook. You guys can watch it on the TAPG Facebook page. That's
Nice.
Nice.
Website right now.
So you could do that too. You all belong to other fields and organizations besides AEE. We have been presenting to each other forever. And it's great. We share because we're sharers. And we network, and we like that. It makes us feel good, and it energizes us to go back out for another 6 months or a year. And that's great, but it's time to turn around and present what we do out to the rest of the world. And so join us in doing those sorts of things. And you have an opportunity to participate today. We're going to have a core meeting, which I know does not sound very exciting, but a core meeting to talk about what are our next steps. What should we be doing to keep validating adventure therapy and merge ourselves with the bigger field of healthcare. So come to our meeting this afternoon. Go out and be superheroes.